One of the challenges in translating epigenetic therapy to the clinic has been being able to have sufficient effect on the epigenome in order to yield a therapeutic response. Many studies to date have focused on a single layer of epigenetic information, of which there are many. One of the most commonly known is that of cytosine methylation, for example, and the DNA methyltransferase inhibitor drugs have been used for many, many years in an attempt to reverse abnormal cytosine methylation. But that is only one layer of the epigenome, and cytosine methylation does not carry out gene regulation by itself, but does so in concordance with several other layers of chemical information in the epigenome, which include various different histone modifications, the three-dimensional structure and architecture of the genome, which folds in specific ways that enable genes to be expressed in coordinated manners, as well as non-coding RNAs, which have less clear but important functions as well in controlling gene expression through epigenetic mechanisms. So one of the challenges that we have to improve the efficacy of epigenetic therapy is to figure out how to rationally combine it in a way to yield the reprogramming of the epigenome in such a way as to synergistically reactivate aberrantly repressed genes, for example. And another challenge is to target those drugs to patients who are most likely to respond based on their somatic mutation profiles so that we can be sure of getting the maximal response based on the tumors having those particular defects in them. So the lecture today was about how using a organoid culture system and treating primary human acute myeloid leukemia specimens over the course of 4 weeks with a combination therapy regimen that includes 5-azacitidine, which is one of the DNA methyltransferase inhibitors, in combination with drugs that target another protein called LSD1, which is a histone demethylase that takes off the histone 3, lysine 4 activation mark from histones at enhancers of genes, might potentially synergize to treat leukemia. So we obtained a cohort of 90 patients who were enrolled in a clinical protocol in the United States, and putting the specimens into this culture system, we were able to identify that the patients that really have a synergistic response to these drugs are those that have mutations in TET2, which is one of the known founder mutations of AML. Now, there's been an effort to treat, or it's been known that TET2 mutation can lead to aberrant increase in cytosine methylation. But that effect, that knowledge has been translated into thinking that hypomethylating agents like azacitidine or decitabine would be more effective in those patients, which is really not necessarily the case. So probably we're missing something important about how TET2 functions. What we found, well, what we previously reported is that TET2 mutant AMLs also have a very profound reduction in the abundance of cytosine hydroxymethylation, which is also another epigenetic mark, and in particular linked to the activity of gene enhancers. So in the talk, we described how TET2 mutant leukemias have a simultaneous defect in the activity of enhancers due to the loss of hydroxymethylation and loss of activity of promoters due to an increase in cytosine methylation. We showed that the loss of hydroxymethylation in enhancers results in increased binding and activity of LSD1, specifically at those sites, and for that reason, targeting LSD1 plus azacitidine yields effects that are synergistic in reactivating expression of genes by hitting both types of elements simultaneously. That enables their physical interaction through looping of enhancers to promoters. And most importantly, at the biological level, while either of those drugs alone does not really have an effect on leukemia stem cells, the combination of both leads to extinction of leukemia stem cells in vivo, of primary human TET2 mutant leukemia stem cells in vivo. And so we propose that this combination be used in clinical trials that are enriched for TET2 mutant patients, and the proper correlative science be performed to determine if this will validate prospectively in the clinical trial setting. There are some trials that have been initiated or proposed that I don't believe are going to enrich for those patients specifically. So, but we might capture a few patients in those trials that have TET2 mutations. But it would be nice to see trials where patients are selected up front based on their mutation profiles to be enrolled in that treatment to thus enrich in those that have TET2 mutations. Importantly, I should say that Not all TET2 mutant patients will respond. We found that patients that have concordant mutations in TET2 plus mutations in DNMT3A do not respond. And that is because there's just a different kind of disruption in the cytosine methylation patterning of those patients.